Jay Vanston, and the title of this lecture is Pain Management Fundamentals. It is part of the fellowship training of the Cooper University Palliative Medicine Service. It is meant to be a preliminary discussion prior to engaging in case management talks. The objectives of this presentation are a few. The first is to give a brief review of pain pathways, which were reviewed in a prior talk. Also to illustrate how different medications interfere with the transmission of pain signals, to review the characteristics of common opioids, and finally to allow for a case discussion. So before we even begin the discussion, I think the important thing is to determine what is pain. And the common definition that's put forth is that pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. I think sometimes a better description is whatever the experiencing person says it is, existing whenever the person says it does. And I think the main point of these two slides is that pain is inherently subjective, and we need to trust the patient and when he's saying he's in pain and determine what the cause is. As I think all of us have been taught from medical school and through residency, that the most important part of any exam is taking an excellent history, and I think that is no less true for a pain history. An old saying of mine is that a patient, or that I was taught, was that if you listen to a patient long enough, they'll tell you what's wrong with them, and if you take a little bit longer, they'll tell you what's wrong with you. So history is absolutely critical. And when, at least from a practical standpoint, when I'm determining or taking a history, I try to determine what kind of pain the person has, and at least to drop it into one of a few buckets. I like this quote. It goes, when I have the gout, I feel as if I was walking on my eyeballs. So I thought it was a great description of pain. So the first category, or the first bucket, is what we call nociceptive pain. It is the most common type of pain that we run into on a palliative medicine service. And I think the important thing to remember is that it's caused by stimulation of intact pain receptors and transmission along normal nerve pathways. Oftentimes it is sharp, it's aching, or throbbing. And the two categories that we talk about all the time are whether the pain is somatic or visceral in nature. Somatic pain is the pain that is extremely well localized and easy to determine. Oftentimes the things we run into clinically in the hospital is incisional pain, or bony pain, or pleuritic pain. Visceral pain obviously is much more difficult to determine, often described as aching, throbbing, and this is the business of the internal medicine physician to determine what the cause of that is. Common etiologies include ischemia, inflammation, pressure, obstruction, and the like. Neuropathic pain, on the other hand, the second large category, is less common, although we certainly see it frequently enough, and it is indeed a treatment challenge. It involves injury to or disease of the peripheral or central nerves, and the important thing to remember is that this involves abnormal processing, that the nerves are not acting or firing in a way that they should. Oftentimes the descriptions are tingling, burning, shock-like, lancinating, throbbing in nature. And again, it can be injury anywhere along the ascending neuronal pathways or the descending pathways, which we'll talk about in a little bit. From a very practical perspective, and this is something that I use frequently on the floors, is I determine whether the pain is opioid responsive or not. Because at least if I know that the pain is opioid receptive, even if it's for a short period of time, I know that that particular opioid can be used in my armamentarium, and that the issue may be more around dosing of that medication or timing of it. The other questions I ask is the pain chronic versus incidental, occurs when a person moves suddenly or has a sudden, or is it procedure related? You'll notice, and you'll come across in many textbooks, a number of pain evaluation tools, things like the behavioral pain scale or the critical care pain observation tool. I'm not going to get into a lot of details about pain scales during this presentation. I think the greatest value, a number of studies have been done looking at pain scales, and the reality is that no particular scale is remarkably better than any other. I think the important thing to remember is that the scale has to be meaningful to the patient, it has to be meaningful to the practitioners, and the practitioner and the patient need to agree on the value of that tool and that they're going to use that as the basis of their communication. So this is an example of behavioral pain scale. Looking at whether a person is restless, tense muscles, frowning, grimacing, and patient sounds, and then determining along the x-axis whether there's none of those things, mild, moderate, or severe signs of pain. This is an example of a critical care pain observation tool, and again, it can be quite useful provided it is an active part of the chart and is an active and assessed regularly and consistently. In regard to evaluating pain, the other thing that is important to remember is the concept of total pain, which was first brought forth by Dame Cicely Saunders, and certainly in our experience in palliative medicine at Cooper Hospital that we run into this on a number of occasions. That pain has many dimensions, that not only it doesn't involve physical dimensions, which we'll be focusing on today, but there are also psychological dimensions to pain, there are spiritual dimensions to pain, and even pain can be increased or decreased by the community in which a person lives. So again, we're going to be focusing more on the physical aspects of pain and medication management today. But just a rapid review, and this was reviewed last week by Dr. Mark Angelo on the transmission of pain, but I don't think it ever hurts to go over it again. Remember that there are pain processes: transduction, conduction, transmission, perception, and modulation. And as you recall, there are afferent pain fibers. They will carry a signal to the spinal or posterior horn of the spinal cord. They will synapse that area, decussate or cross over and go up the spinothalamic tract to the thalamus, and then from the thalamus to multiple areas of the brain and cortex. The first step in this obviously is transduction, and mechanical, thermal, or chemical injury can cause the beginning of the process of pain transmission or pain. Remember that whenever there is any tissue injury, potassium is released. This causes a reaction of the vessels of bradykinins, prostaglandins are developed, and eventually there's almost a chemical soup that develops in the periphery that sets up the next step in the pain process. Platelets release serotonin, mast cells release histamine, the vascular endothelium release bradykinins, and the like. Just from a basic standpoint, remember that the cell walls contains phospholipids. These phospholipids are broken down via phospholipase A2 to arachidonic acid. Arachidonic acid is broken down via cyclooxygenase to prostaglandins, which participate or begin that inflammatory process and increase the likelihood that the axon will fire and will, the nociceptor will fire and begin to the pain signal. Remember that in interventions, if there's tissue injury, that steroids will block phospholipase A2, thereby blocking the formation of arachidonic acid and ultimately prostaglandins. Lower on this chain, non-steroidal anti-inflammatory drugs will block cyclooxygenase and again block the formation of prostaglandins. COX-2 inhibitors are even more specific. The second step is conduction, and the important thing to remember is that once the nerve begins to fire and the sodium and potassium channels open, that the action potential is an all or none phenomenon. Sodium enters the cell, potassium moves out of the cell, and it continues down the line almost as if this were dominoes. Anticonvulsants, anesthetics, for example lidocaine, will block these sodium potassium channels, and thereby blocking the action potential. Transmission is the next phase, and this occurs in the dorsal horn of the spinal column. And what happens is the signal from the primary afferent neuron results in the release of kind of packets of neurotransmitters, including substance P. These will synapse on the spinothalamic tract neuron and continue to send the signal up the spinal cord. This is where opioids act, and they often act on the mu receptor, thereby blocking the release of these packets such as substance P, and will inhibit the pain transmission to the spinothalamic neuron. Remember, and as was discussed last week, there are mu, delta, and kappa receptors. From a very practical standpoint and in terms of day-to-day management, we focus on the mu receptor and consider that opioids will act in all of these areas. Ongoing research is continuing in the evaluation of these receptors and how we can better control pain. So morphine, as was noted before, binds at the opioid receptors, as do other opiates. And the transmission continues to the thalamus, and from the thalamus we move into the phase of perception, where pain goes to the somatosensory cortex. So this can trigger memories of pain before, can trigger reactions to pain. The associative cortex will bring in other reactions as well, to the limbic system, which explains why there's such an emotional component to pain, and throughout the cortex. Remember that when we think of pain, we think of kind of those positive elements that cause the pain signal to come north, but also our bodies have a natural tendency to modulate or inhibit pain. Remember that a person who has pain doesn't continue to have pain at the same intensity until complete healing has occurred. And so initially, a person will have a sharp intake of pain, and almost immediately there'll be a modulatory component to that. And the key neurotransmitters associated with modulation, or these descending tracks, include serotonin or norepinephrine. And these will act to inhibit at the area of the spinothalamic, from the first and second order neurons, and kind of again try to diminish that ascending pathway. This is where antidepressants will act, such as tricyclic antidepressants. Also medications like Cymbalta or venlafaxine, which block the action of serotonin increase serotonin and norepinephrine as well. So let's get into some practical aspects of management and the use of medications. One of the workhorses we use in palliative medicine all the time is opioid therapy, and certainly opioids have been around for quite some time. You can see this quote from Thomas Sydenham in 1680: "Among the remedies which has pleased Almighty God to give man to relieve his suffering, none is so universal or efficacious as opium." So I think it might be worthwhile to review specific opioids. The first is morphine. It is often considered the gold standard, and we talk about the relative potency, and we give that a value of 1. Its onset is IV, is in minutes. Its peak effect IV is in about 10 to 15 minutes or so, and has a half-life of 3 to 4 hours. So that often tells us a person's at a steady dose of morphine that within 24 hours, 5 or 6 half-lives, they've achieved steady state. It is water soluble, and that's important to remember as compared to medications like fentanyl. And its metabolism is via glucuronidation. The important thing to remember with morphine is that one must be cautious with renal insufficiency, because metabolites do develop and can cause increased hyperexcitability, agitation, delirium, and even seizures. Dilaudid is another opioid that we use very frequently. has a relative potency related to Dilaudid of morphine of 1.5 milligrams of IV Dilaudid is approximately 10 milligrams of IV morphine. I think the important thing to remember is that these potencies are generalities and should be thought of in that way. They're certainly useful in day-to-day, but they're not mathematical equations. The half-life of Dilaudid is about 2 to 3 hours, and a metabolism, again, glucuronidation. Dilaudid is also water-soluble. It has better metabolism, although not ideal, with renal insufficiency, and oftentimes that will be the first opioid we reach to if somebody has renal insufficiency, mild to moderate renal insufficiency. Fentanyl is a drug that we commonly use both at Cooper and in the community. It's much more potent than either Dilaudid or morphine. It has 100 micrograms of fentanyl is equal to 10 milligrams of IV morphine. It is lipid soluble, so if this medication is put under the tongue or in the mouth, a large percentage of that will be absorbed directly into the circulation. It has a half-life of about 2 to 4 hours, and its metabolism is via the liver. It causes less hypotension than with morphine, and however, it can also have accumulation with hepatic impairment. I think the other thing, we see this used in the ICU frequently for pain management. The important thing to remember is that commonly in the community, the fentanyl patch is used and for pain management. I think the important thing from a palliative medicine perspective is that the fentanyl patch has no role in the acute setting. When a patch is placed, it takes about 12 to 17 hours to reach peak effect. And when the patch is removed, the drug is still in the system and in the fat stores and continues to be absorbed into the circulation. A very quick rule when kind of on day-to-day management is that the number of micrograms of the patch per hour is about that many milligrams of oral morphine every 12 hours. Again, this is not perfect, but it can give you at least a working sense of how much drug the person's receiving. It's very sensitive to skin characteristics such as temperature and also whether there's good contact with the skin. Just on a personal note, I did have a case once where a patient was stable on a fentanyl patch and he took a nice hot shower when he went to the skilled nursing facility, and within a very short time he was unresponsive. In my mind, it is best used when a person has an unreliable GI tract. The things we run into frequently at Cooper are people who have malignant bowel obstruction or partial bowel obstruction. The other important thing is that the pain control is stable, that you've established what their opioid needs are with an IV infusion, and that you know how much drug they're going to be needed. Again, fentanyl patch does not work well for kind of dynamic situations. Methadone, which will be a separate presentation in and of itself, but it's important to at least be aware of, is a mu receptor agonist and an NMDA receptor antagonist. Methadone is much trickier to use than with other opioids. It has a long and variable half-life. In one individual, maybe 24 hours, in another it could be 48. It has multiple drug interactions, and we always have taken into consideration the person can have QT prolongation with this or with the interaction with other medications. The important thing to remember is that methadone has relative potency depending upon baseline opioid usage. So if a person is on a high dose of morphine, for example 1500 milligrams a day, that person's the relative potency of methadone may be 20 to 1, as compared to if they're on 60 milligrams a day, the potency may be only 3 to 1. So oftentimes one must be very careful in converting from another opioid to methadone and take into account the potency, or the sliding scale potency of this drug. Neuropathic pain, which is again going to be a topic in and of itself in future lectures, is also a strong consideration in the evaluation and history of patients. In the acute setting, opioids still can remain as your key workhorse to control pain. And oftentimes with that workhorse, we'll add in medications like antiepileptics, tricyclics, serotonin, norepinephrine reuptake inhibitors, and even anti-inflammatory drugs such as steroid or non-steroidal anti-inflammatory drugs. So we will stop there. And again, this was just meant to be a quick overview in anticipation of case discussion. And so we will see you Thursday morning. And I hope this has been helpful. Thank you.